My experience has been with many of these patients, I typically get the answers, the preventative medication, the one that will prevent me getting the next asthma attack, or the one that'll prevent me reducing the long-term effects of diabetes. I can't take them because I can't afford to pay for them. Where I think the people fall in between is always that working poor. So you have people that are working, so they don't have any coverage because they are working, they're on social assistance, yet they have low-paying jobs and jobs that don't have any sort of extended health insurance. So now you have a person that doesn't have a high-paying job, they don't have insurance, and yet they're still having to pay for the same medication that someone that has a much, much higher income has to. So I think that's the area that really suffers. Well, I think there's two things I would do to improve the system. I think at the end of the day, we still need to improve the prescribing habits of the physicians. Too often I still see prescriptions for drugs that have little or no evidence. And the ironic part about it is that the drugs that do have the most evidence for most conditions tend to be the older drugs because they have more data on them, and they tend to be cheaper. So improving the evidence not only will actually improve patient outcomes, but it actually will decrease costs because physicians will tend to prescribe drugs that are less expensive and have more evidence. So I think that would be the first thing I would do. And certainly the other thing I would do, whatever savings you would get from that sort of a transformation in the prescribing habits of physicians, I would transfer those savings to getting better coverage for the working poor. I think the lower income population, there needs to be a larger number of them that get benefits for drugs through Pharmacare.